2% of our body weight. It is very vital organ, important organ, has many functions, and unfortunately we don't have a replacement for these functions if the liver fails. Examples of functions include protein synthesis, enzyme synthesis, nutrient processing, extraction, storage, metabolism and excretion of drugs and waste products. Also, it has important immune function, and it hosts macrophages. To produce also secrete bilirubin, one of these waste products, and bile salts, which are important for absorption of fatty food. Regarding the anatomy, the liver is unique in that it receives oxygenated blood from two sources, dual blood supply, we call it, and that blood flow to the liver is around 1500 ml per minute. The sources of this oxygenated blood comes from the hepatic artery and the portal vein. The portal vein brings more blood, which is partially deoxygenated, while the hepatic artery brings fully oxygenated blood. Together they contribute volume-wise. The portal vein may bring 70% of the volume, and the hepatic artery 30%. Oxygen-wise, around 50-50. The portal vein is formed by the junction of the superior mesenteric vein and splenic vein behind the neck of the pancreas. The inferior mesenteric vein usually either join the splenic vein or join the junction of the splenic vein and the superior mesenteric vein. Regarding the hepatic artery, it's a branch from the celiac trunk. We have three branches for the celiac trunk: the splenic, the gastric, and the common hepatic. Common hepatic, we call it common hepatic until it gives the superior, until it gives the gastroduodenal artery. After that, we call it proper hepatic artery. There are three main hepatic veins that drain blood from the liver directly into the IVC. We have the right hepatic vein, the middle hepatic vein, and the left hepatic vein. There are additional veins that drain the caudate lobe directly into the IVC, and sometimes there is a variation that we have additional inferior right hepatic vein, which is a variation where there's a big inferior hepatic vein. This is the surface anatomy of the liver and the old classification of the liver into left and right according to the falciform ligament, which has been abandoned. So it's not anatomical classification, but we can see here, you can see the pointer. This is the coronary ligament and become triangular ligament. And here we have the same thing, coronary ligament on the right side and then triangular ligament. This is the falciform ligament, and there's ligamentum teres in its tip, which is the remnant of the umbilical vein. This is anterior view. This is inferior view of the liver, and here we can see the peritoneal reflection. This is the gallbladder cystic duct joining the common hepatic duct to form the common bile duct. This is the main portal vein. This is the SMV stump and the splenic vein stump. This is the celiac, and from the celiac, this is aorta. From the celiac comes the common hepatic artery. This is the gastroduodenal artery stump, and then become what we call proper hepatic artery. This is posterior view of the liver. And here we see the bare area. This is the area where there is no peritoneal covering of the liver. It's attached directly to the diaphragm here. This is the reflection of the peritoneal covering and the coronary ligament and triangular ligament. Here you can see that the IVC is almost encased by the liver, and many times you find even liver parenchyma behind the IVC, where there's complete encasement. And here we can appreciate that the hepatic veins, their course is usually intrahepatic. You don't see them outside the liver because they directly go into the IVC, which go through the liver. Usually there's no much length of the hepatic veins that we see outside the liver. Here we can see, and this is what we can see from the right hepatic vein on the from outside. هلا ندخل على حكينا هاي الصور اللي شفناها surface anatomy. This is internal anatomy of the liver, which is the more important. Here we can see this is the venous anatomy. We have right, middle, and left. And here the portal vein anatomy divided into right and left. Then the right is divided into right anterior and right posterior. This is right posterior, right anterior. The left is divided into left lateral and left medial. And this is all simplified anatomy. So in reality, we have branches that are reaching all parts of the liver. Here is also the arterial anatomy, also simplified with the portal vein anatomy, right and left, and then branches. It follows the branches of the portal vein. This is the biliary anatomy, also similar. Simplified, we have right and left hepatic duct. They join to form the common hepatic duct, which is joined by the cystic duct to form the common bile duct. Goes behind the stomach and then enter the pancreas and get into empty, open into the second part of the duodenum at the ampulla of Vater. So this is when we see all the structures together, also simplified. But this is just to tell you that the anatomy of the liver is complex. There are many important structures inside the liver that you should be aware. We are operating with the liver, we should be aware of this anatomy and these structures to know what to preserve and what to resect and where to expect these structures. Okay? Regarding based on the anatomy, the internal anatomy of the liver, there has been the classification, the anatomical classification of the liver, which is called Quinones classification, which depends on the arterial and venous and portal venous supply, as well as venous drainage and biliary drainage. So we have 8 segments. Segment 1 is the caudate lobe, which is a kind of independent in terms of venous drainage. It receives branches from either both the right and left portal vein and hepatic artery regarding the blood supply, but the venous drainage is independent and it drains directly into the IVC, and in case of hepatic vein thrombosis, like in Budd-Chiari, usually there will be hypertrophy of the, and in most cases of cirrhosis also, there will be hypertrophy of the segment 1, the caudate lobe, because its venous drainage is maintained. هلا بعد segment 1 we have additional 7 segments. Segment 2, 3, 4, 5, 6, 7, 8. And زي ما انتم شايفين we can memorize them as clockwise. We start with 2, 3, 4, 5, 6, 7, 8. يعني memorize this as clockwise from 2 to 8. 2, 3, and 4 comprise the left lobe, while 5 to 8 comprise the right lobe. You can see that this division is based on portal and arterial blood supply as well as hepatic veins. So the middle hepatic vein, its course is usually the line that divides the liver into right and left. And in this, the line that divides, and when we want to know the surface, a line landmark, we call it Cantley's line for the right and left. It is from the bed of the gallbladder till we reach the middle hepatic vein. If we draw a line, that's usually where there's the line demarcating right from left. The right hepatic vein divides the right lobe into right anterior and right posterior. The left hepatic vein divides the left lobe into left lateral and left medial. When we do resection, we can do different types of resection. Sometimes we remove just one segment, we call it segmentectomy. Sometimes we remove two segments, sectorectomy. We can call it this left lateral sector, left medial sector. We can remove the whole lobe, we call it hepatectomy or right hepatectomy or left hepatectomy. If we remove 5 to 8, this is right hepatectomy. If we remove 2, 3, and 4, this is left hepatectomy. We may remove 4 with the 5 to 8, we call it extended right. Or if we remove 5 and 8 with the left lobe, we call it extended left. Sometimes we do central resection, and sometimes we do non-anatomical resection according to what type of lesions we are dealing with. But we can remove as much as 70-75% of the liver volume if it is normal parenchyma, and the liver has the ability to regenerate after resection. So after 1 month from resection, the liver will compensate, will hypertrophy, and it will restore 90% of the original volume before the resection. Okay, if the liver parenchyma is normal. If it's cirrhotic, or if there is fatty liver, there will be decreased regeneration, and that's why in these patients we will not be able to resect as much as we can from healthy normal parenchyma. Any questions so far?
لا دكتور.
Okay, so we'll proceed. So we start with benign liver tumors, and the first and the most common of these is the hemangioma. The hemangioma can be capillary or cavernous. We don't understand the exact etiology. We think mostly it is congenital, but there is a relation to hormones, and it is more common in females, young females, and it may be affected by estrogen. But here there is no malignant potential, so usually we don't perform surgery until it's causing a problem. Most of the time it's discovered incidentally when we do imaging for something else. Sometimes it can cause a problem like abdominal pain. And if there's abdominal pain, we have to make sure that the cause of the abdominal pain is really from the hemangioma. So we have to rule out other causes of abdominal pain in that area. And the hemangioma has to explain that pain. So usually for hemangioma to cause pain, it needs to be large and causing stretching of the capsule. But small hemangioma inside the liver parenchyma usually doesn't cause pain. So it should not be the cause of the pain. Another problem that hemangiomas can cause اللي هي ممكن تعمل platelet sequestration syndrome, especially in pediatric age group, and cause thrombocytopenia. It can cause an acute inflammatory reaction and fever with elevated ESR, C-reactive protein. And in that case, when there is a problem from hemangioma, may also cause rarely high output cardiac failure, especially if it is very large. In that case, then that will be an indication for resection or intervention for the hemangioma. How we diagnose hemangioma? Usually by imaging. What characterizes the hemangioma is that we do imaging, what we call liver protocol CT scan or MRI, which is triphasic. We have the first phase is the arterial phase, where the contrast is in the arterial system. Then we have the portal venous phase, and then we have the delayed phase. So in the arterial phase, there will be, as in this one, this is pre-contrast CT scan. And here we can see the contrast in the aorta. We say peripheral enhancement, so the edges of the lesion, which is we think is hemangioma, there is contrast enhancement. On portal venous phase, which is a later phase, usually 2 minutes after injection of the contrast is reaching the portal circulation, and so it's going deeper and deeper with time. So the blood supply usually for the hemangioma comes from the periphery to center, and so the contrast will go from periphery to center. We call it centripetal contrast enhancement, centripetal blood flow. And so in delayed images also there will be more filling of the hemangioma with contrast, and this is usually very suggestive of hemangioma. MRI can add to that in T2 weighted images where static fluid will appear bright, as in CSF. The hemangioma, because the blood flow slowly inside it, also will appear bright even without contrast. And if we get the contrast and do the triphasic, it will appear the same pattern of enhancement as we saw in CT scan. If you are not sure or suspicious, we may do a labeled RBC scan to confirm the diagnosis.
هاي الصورة أي phase؟
This is not phasic. This is T2 weighted images before contrast. This is MRI, is not CT scan, okay? But we can get the contrast in MRI in the same way as for CT scan. But this is just, I brought this image to show you the brightness on T2 weighted images. كيف نعرف إنه T2 weighted images بتطلع على CSF تكون bright, and T2 weighted images static fluid or fluid moving slowly will appear bright without contrast. Okay? Like this fluid inside the chest, for example. زي ما حكينا, there's no need for intervention. هلا دائما common say that biopsy is contraindicated in hemangioma. Usually, if you are suspecting, if you are diagnosing hemangioma, you diagnose it through imaging. If you are not sure of diagnosis and you are still suspicious, you may do biopsy. Take precautions. Yes, there is some risk of bleeding, but it is less than the risk of, for example, missing a cancer. So sometimes the images will not be typical, and we may do biopsy, but most of the time we are able to reach the diagnosis without biopsy for hemangioma. Another benign liver tumor اللي هو adenoma. Here we have benign liver cells, benign appearing liver cells with the absence of portal triad or bile ductules. It is more common in females. It is strongly related or connected to estrogen. So most of the women who develop the adenoma have history of oral contraceptive pill use, and usually it is seen in the childbearing age. In addition to oral contraceptive pills, steroids and glycogen storage disease also increase the risk for development of adenoma. Here, the difference from hemangioma is that there is malignant potential for adenoma. It may transform into hepatocellular carcinoma, and because also of complications even without transformation into malignant hepatocellular carcinoma, the risk of rupture or bleeding inside the tumor is significant. So usually we recommend resection of most adenomas, especially for sure symptomatic, and most of the asymptomatic lesions, especially if they are more than 5 centimeters. Sometimes we take the conservative treatment as an option in small adenomas in those women who are taking oral contraceptive pills or who are close near menopause. in these cases, there's a chance that if we stop the OCPs or if the patient get into menopause, there may be shrinkage and regression of the adenoma, and we have to follow these patients with the imaging. And if we see that the lesions are decreasing in size and not progressing, then that will be reassuring for us that conservative treatment to be continued. If there is progression, increase in size, that's usually an indication for surgery and intervention. So most of the time we intervene for adenomas because of the malignant risk and because of the risk of rupture and bleeding. This rupture can be, or bleeding can be inside the tumor contained within the liver, which will cause acute pain, or if the tumor is close to the surface of the liver, there may be bleeding into the peritoneal cavity, which can be life-threatening. We usually recommend for these patients not to get pregnant if they have adenomas during the observation period until we do something for them. How we diagnose adenoma? Usually history first, with the suspicion in a young childbearing age woman taking OCPs. We may do biopsy to confirm the diagnosis, but they will appear as bright in the arterial or enhancement on the arterial phase and hypodense in the, this is MRI. They may appear dense in T1 without contrast, a little hypodense to the surrounding tissue. And T2 weighted images, if we remember, hemangioma was bright. Here we can see it's isodense, similar to the surrounding liver parenchyma. And in the late phases, there may be some contrast still there, but most of the contrast is gone. We may, usually we will need to do biopsy to confirm the diagnosis, but we may do clinical diagnosis by imaging. If the patient is taking OCPs and young child bearing age. We have to...
findings in Surah.
عفوا؟
تعيد findings in Surah لو سمحت.
هلا at T1 weighted images, it is hypodense compared to the rest of the liver. On T2 weighted images, it's isodense. On the arterial phase, there is diffuse enhancement. Okay, or this arterial phase, we can see the contrast in the arterial system. On delayed phase, there will be the contrast is almost gone from the mass, from the tumor. But this is not diagnostic finding, so this is suggested finding for diagnosis. We have to differentiate it from, we can differentiate it by MRI from hemangioma, but we have to differentiate it from other benign tumor اللي هو راح نحكي عنه اللي هو focal nodular hyperplasia. وهون focal nodular hyperplasia is similar to adenoma, that it contain normal looking liver cells or hepatocytes, but here the difference is that they contain bile ducts and portal triad in these tumors, and they have a central fibrous septation called, we call it central scar. There's fibrous septi between the tumor cells, and in the middle there's what we call central scar. Also, this is more common in women, usually young age. They are more likely to be symptomatic than hemangioma. All of these lesions can be multifocal, including hemangioma and adenoma. And they may coexist with hemangioma. Hemangioma is very common. You can see with it any type of other tumor or any type of liver lesions. If we see the central scar in these lesions, usually that will help us to guide us to the diagnosis of focal neural hyperplasia. But many times we need to do biopsy to confirm the diagnosis of focal neural hyperplasia. Here the lesion, if symptomatic, we usually recommend resection, or if it is increasing in size on follow-up. So symptomatic usually will be in the form of abdominal pain because of the capsule stretching. We recommend resection in that case. If we follow the conservative approach and we saw that it is enlarging, then we have to also recommend resection. We see it on MRI. So this is a T1 weighted images. We can see that it is a little bit hyperdense. This is what we call the central scar, also hyperdense compared to the rest of the parenchyma. In T2 weighted images, actually this is T2. This is T2. So hyperdense, central scar. In T1 weighted images, hypodense, the central scar. لما نعطي contrast في arterial phase, there is enhancement of the periphery with the contrast spared. On the red images, usually the contrast will become enhanced. بس مش مبين بالصورة هون. This is too delayed, and the contrast is gone from the periphery. So this central scar usually help us tell us that this is mostly focal neural hyperplasia. Sometimes it doesn't appear in the images, and since it affects the same age group as adenoma, we may do a biopsy, or sometimes we have a special type of contrast that's given with MRI that's secreted in bile. So in case of focal neural hyperplasia, since it contains bile ductules, it will enhance, while in case of adenoma, it will not enhance. But this contrast is not available in Jordan right now. حكينا الفوكال neural hyperplasia also usually doesn't have malignant potential, but if it is symptomatic or enlarging, we usually recommend resection. Another benign liver lesion اللي هم simple liver cyst. لما نحكي عن hydatid cyst نحكي عن simple non-parasitic cyst. لما نحكي simple يعني we mean that they are lined by single layer of either cuboidal or columnar epithelial cells. They can be multiple. Also, they are more common in females than males. Most of the time discovered incidentally by imaging for something else. They may cause pain, similar to any other lesion, by stretching the capsule, or they may cause mass effect if they are compressing the nearby structures, like the stomach, for example. They may cause early satiety, or they may compress the colon. Diagnosis is usually by CT scan or ultrasound, where we will see a water-filled or fluid-filled lesion with no septation, no structures in the wall. And if they are symptomatic, they are and causing a problem, there's an indication for deroofing, what we call deroofing. This is how they appear on imaging. Here we can see a large cyst. We can see the fluid density here. There are no septations. طبعا هنكون شايفين multiple levels. We look at the wall. It is simple, thin wall. So there are no structures, no nodules. We call it cyst adenoma, for example, which is not a simple cyst. This one is simple, no lining, no septation. And so no, usually We just observe these cysts unless they are causing a problem. If they are causing a problem, we do what we call deroofing. And this deroofing can be done usually by laparoscopy. We remove the part of the cyst that's coming out from the parenchyma so that the fluid that's secreted by the lining will be drained into the peritoneal cavity and there will be no cyst anymore. This is an example of laparoscopic deroofing for a simple cyst. Other benign liver lesions include nodular regenerative hyperplasia, bile duct adenoma, hamartoma, mesenchymal hamartoma, leiomyoma, mesothelioma, lipoma. All these are not that common, but we mention them because we may encounter them, especially if we are doing staging laparoscopy or diagnostic laparoscopy before operating for example, gastric or pancreatic cancer. These lesions may appear on the surface, especially the bile duct hamartoma. They may appear on the surface and they may mimic deposits or metastasis on the surface of the liver. So when we see them, we have to take biopsy and send it for frozen to make sure that, to confirm that they are metastasis or benign before doing the next step. If they are going with metastasis, usually there is no rule for resection and we spare the patient a major surgery, which will not be curative. If they are adenoma or hamartoma and they are not metastasis, according to the frozen, then we can proceed with a surgery which can be curative. Any questions in benign liver lesions so far? Okay, we'll proceed to malignant liver lesions. We're talking here about malignant liver tumors, primary liver tumors. We're not talking about secondary liver tumors. So the most common malignant liver lesion is actually from metastasis. But our talk today will be about primary liver tumors, and the most common of these is the hepatocellular carcinoma. It accounts for 90% of all primary liver tumors. It is common in certain parts of the world where there is where the hepatitis is endemic. Fortunately, we don't see it that much here. Worldwide, it's the fifth most common cancer, and it's also the third leading cause of cancer-related mortality. And most of the time, cirrhosis is the risk factor that is leading to hepatocellular carcinoma development. And here, if you remember the benign lesions, most of the time, all of them were more common in females. Here, the hepatocellular carcinoma is more common in males compared to females. زي ما حكينا, they develop usually in cirrhotic people. Their incidence varies from one country to another, with the highest incidence in China, Southeast Asia, and certain parts of Africa. Hepatitis B and C contribute to nearly 3/4, 70 to 80% of all cases of hepatocellular carcinoma worldwide. Their relative contribution vary from one country to another. For example, in Japan, it is hepatitis C. In China, it is hepatitis B. In Europe, hepatitis C. In Africa, hepatitis B. In Egypt, hepatitis C, and so on. Here in Jordan, we have a kind of mix, both hepatitis C and B. In the past, hepatitis B was more common, but we are seeing more cases of hepatitis C recently. So, after viral infection with the chronic inflammation, the HCC develops usually tens of years after the infection. And since there is vertical transmission in case of hepatitis B from mother to child, like what we see in China, the infection is since childhood, and so we see the tumors in young age group from hepatitis B, while with hepatitis C is usually acquired, and so we see the tumor usually at older age group, usually in the 60s. Other causes of cirrhosis also contribute and can be a risk factor for hepatocellular carcinoma, including alcohol abuse and hemochromatosis, non-alcoholic steatohepatitis, primary biliary cirrhosis, autoimmune hepatitis, all can be a risk factor for HCC. But primary biliary cirrhosis and autoimmune hepatitis, they are not common they increase it compared to general population, but the risk is not as high when you see other types of cirrhosis. Also, other risk factors, if the patient is cirrhotic, including the male gender, increasing age, and advanced cirrhosis. If the patient is not cirrhotic, we have other risk factors, and the most common of these is here. Adenoma can develop into hepatocellular carcinoma, aflatoxin exposure, metabolic liver disease, alpha-1 antitrypsin, Wilson disease, porphyria, thalassemia, and so on. So how we diagnose hepatocellular carcinoma? Ideally, in anyone who's cirrhotic, there should be a screening program for hepatocellular carcinoma. In all patients who are cirrhotic, every 3 months they should see a hepatologist, and in the clinic they should undergo ultrasound and alpha-fetoprotein, which is the tumor marker for the hepatocellular carcinoma. So if the ultrasound is suggestive of anything, then they should do more accurate imaging, CT or MRI, and to detect these lesions as early as possible. We should not rely on symptoms or changes in liver function to diagnose HCC. So these patients are cirrhotic, so it is expected for them to have jaundice, to have elevated INR, and to have ascites and abdominal distension. If we want to wait until these tumors are causing symptoms like weight loss, abdominal pain, and anorexia or mass effect, then it is usually too late to treat these lesions. So we try to do screening to detect these lesions before they are symptomatic. And one of the ways is the tumor marker, which is alpha-fetoprotein. It is not 100% sensitive nor specific, but it is very helpful. So it can help us in diagnosis early diagnosis of HCC in high-risk patients. So how we diagnose hepatocellular carcinoma is usually by imaging. So if someone is cirrhotic, which means that he's at risk for development of HCC, we rely on imaging to diagnose HCC, which is by doing the liver protocol, CT or MRI, and we see the pattern of enhancement, which is in the form of arterial enhancement and what we call delayed washout in the portal venous phase. And why this happens? Because the blood supply of the hepatocellular carcinoma is mainly from the hepatic artery, so the contrast will reach it early with the arterial system, and then when the contrast on the portal venous phase, when the contrast reaches the portal venous phase, the contrast will be washed from the tumor, and the surrounding liver will enhance compared to the tumor. This is the CT scan in the arterial phase. We can see here enhancement on the arterial phase. This is MRI. And here, this is T2 weighted image. We see a little bit hyperdense lesion here. On T1 weighted images, it is hypodense. But let's go to the contrast. Here on the arterial phase, there is enhancement. And on the portal venous phase, there is wash out. So the surrounding liver will become more enhanced than the tumor itself. So if we see this pattern of enhancement in a patient who is cirrhotic in two different imaging modalities or two occasions of imaging, or if we see it with normal alpha-fetoprotein, or if we see it in one imaging modality with elevation of alpha-fetoprotein, this is enough for diagnosis of hepatocellular carcinoma without a biopsy. Okay? And those who are not cirrhotic or the pattern of enhancement is not typical and the alpha-fetoprotein is not elevated, we may need to do biopsy to confirm the diagnosis. But most of the time in cirrhotic patients with this enhancement pattern, we don't need to do biopsy. This is the gross image of the tumor after resection, and we can see it's a little bit whitish in color with rounded edges. What's the treatment? We have curative treatment and we have palliative treatment. Curative treatment consists of surgical resection or liver transplantation, and surgical resection is the if when feasible will be a first choice. Liver transplantation is usually done when surgical resection is not feasible. What will decide whether to go to surgical resection or liver transplantation is the function of the liver. Again, most of these patients are cirrhotic, so we have to see what's the function of the liver, which is based on the child classification, child A, child B, and child C. And we have also what we call the MELD score, model of end-stage liver disease. So those who are having compensated liver cirrhosis with preserved function, child A classification, they may be able to tolerate resection. While those who are child C, they will not be able to tolerate major resection, and so they will be more likely to be offered liver transplantation. Unfortunately, not everyone with child C and HCC will be a candidate for liver transplantation because of the shortage of organs. We have to stratify the organs into those who will benefit most from these organs, and that's why we have criteria for allocation of livers for liver transplantation for HCC. So in order to be eligible, you have to, most of the countries in Europe and the United States will follow what we call Benign criteria for these tumors. So the tumor should be, if single, not more than 5 centimeter, or multiple, not more than 3 lesions, and none of these 3 lesions should be should not be more than 3 centimeter, and there should be no extrahepatic disease, and on imaging there should be no gross vascular invasion. Why do we have these strict rules? Because of the shortage of organs. And if we transplant someone with advanced HCC, and we give him a liver which is precious and scarce, he may have recurrence after 1 year, and we are like wasting the liver. So if we have enough organs, maybe we have the luxury to offer him a liver even with advanced disease. But since we have shortage, we have to give the organs, because these organs are national resource and deceased donor organs. And the living donor livers, we may go a little bit beyond Milan criteria, and there are actually other criteria that is followed by some countries. And if we have the living donor or enough organs, we may go beyond Milan criteria to help these patients. And those who are not candidates for resection or liver transplantation, sometimes not because of organ shortage, maybe their comorbidities doesn't allow major procedure. They have heart problem, they have lung problem, they cannot be anesthetized, there's a high risk from anesthesia. We may offer them palliation in the form of chemoembolization, transarterial chemoembolization بنسميها CASE، أو transarterial radioembolization بنسميها TARE، أو blunt embolization اللي هي بنسميها TARE. Embolization, we go through the femoral artery, usually done by interventional radiology. They do common angio, they go through the femoral artery into the aorta and then celiac trunk and then into hepatic artery. And on angiogram, they see what we call the tumor blush inside the liver, which would represent the site of the tumor. حكينا إنه the main blood supply of the tumor is from the hepatic artery. And so then if we include these branches with the spheres, embolization with the spheres, these spheres can contain chemotherapeutic agents, بنسميها chemoembolization, or radioactive material, بنسميها radioembolization, or can be blind just to occlude the vessels. That may help to shrink the tumor or at least slow its growth. So this is TACE or TARE. Other modalities of treatment include ablation, which is killing the tumor cells without removing it in situ. So this can be done by heating or freezing or injection of high concentration of alcohol. Radiofrequency ablation is the most common of these. We can also use, which is heating. Microwave also is utilizing heating. Percutaneous ethanol injection utilize high concentration of alcohol. Freezing. All of these, they work for small tumors, usually less than 5 centimeter, and best if they are less than 3 centimeter. And usually they are used sometimes as adjunct to surgical section to preserve parenchyma. We have multiple lesions. Or if they are done for palliation for those who are not candidates for surgical section, nor liver transplantation, nor any curative procedure. This is the needle that we use for radiofrequency ablation. It's inserted usually percutaneously under ultrasound or CT guidance. If the tumor is seen on ultrasound, then well and good by ultrasound. Once the needle is in the tumor, we open the shanks, and these shanks will transmit heat to the surrounding cells and burn them, usually over 15 minutes. And this will work because of the modality. Will work for small lesions, usually less than 5 centimeter. This for 3 centimeter, and we follow the patient with imaging after 1 month and 2 months, and we make sure we look for the lack of enhancement and necrosis of the tumor and following images. Microwave needle, and similar to radiofrequency, it uses heat, and it can be used also for small lesions less than 5 centimeters. For another palliative treatment is sorafenib, which is a tyrosine kinase inhibitor, which was used for renal cell carcinoma, but was found to be beneficial for hepatocellular carcinoma. It was found to improve survival for those who are not candidates for surgery. And this improvement in survival is statistically significant, so it can be used as a palliative treatment to prolong or extend the life for those with unresectable tumors. Cholangiocarcinoma is the second most common primary liver cancer, and here we are talking about peripheral cholangiocarcinoma. Cholangiocarcinoma can be classified into peripheral, which is when the lesion is located inside the liver, or it can be hilar, when it is in the hilum of the liver junction of the left and right hepatic ducts, or it can be distal when the tumor is below the junction of the cystic duct. distal usually present with jaundice and it will be treated in a manner similar to head of pancreas tumor, while hilar also will present with jaundice, usually the most difficult to treat because of the adjacent structures that will be invaded, including the hepatic artery and portal vein, and usually will need major resections and reconstruction of the biliary tree if resectable. Peripheral is usually inside the liver parenchyma and is treated similar to other liver masses if resectable. It is not that common, but and because there is no obvious risk factor for these tumors, usually presenting late when the symptoms appear, and that decrease the chance of resectability. Risk factors for cholangiocarcinoma include anything that causes chronic biliary inflammation, like primary sclerosing cholangitis, cholelithiasis, parasitic biliary infestation, Caroli's disease, choledochal cyst, bile duct adenomas, cirrhosis, and hepatitis increase the risk of cholangio, but not a similar pattern as HCC. The tumor marker here is CA19-9, and still, as we said, for the alpha-fetoprotein, this CA19-9 is usually elevated in biliary and pancreatic tumors, so it's elevated in pancreatic cancer, gallbladder cancer, and cholangiocarcinoma. It is helpful, but it is not diagnostic, not specific, not sensitive 100%. Imaging, usually there will be heterogeneous enhancement of the mass, and we will not be able to reach diagnosis except by biopsy. And this is grossly how it appears. We can see that the edges are less rounded and it is infiltrative than compared to HCC. This is a simple way of classification or staging for cholangiocarcinoma from Japan, and it was found to be reflected on prognosis. Stage 4, as usual, there are distant metastases. Stage 1, when we have single tumor, no vascular invasion. Stage 2, single tumor with vascular invasion. Stage 3, when we have multiple tumors. شوي بس خليكم. الو دكتور هاني. هلا دكتور هاني. والله عندي محاضرة مع الطلاب. بعد ما أكمل إن شاء الله برن عليك إن شاء الله. أوكي. Okay, so the treatment for cholangiocarcinoma is mainly surgery. Here we don't offer, for peripheral cholangio, we don't offer liver transplantation. For hilar, there are some centers that offer and clinical trials that showed benefit from liver transplantation for hilar. But for peripheral, usually just surgery, which is by surgical resection, liver resection. According to the site and size of the tumor and number, we have to do resection if feasible, if there are no metastases and no extrahepatic disease, and the patient can tolerate the major procedure. For those who present with advanced chemotherapy as adjuvant, we may be given. Unfortunately, the response is not great, and it will be also offered for those who are unresectable as palliative. TACE may be used also, and novel chemoembolization and ablation for small lesions if the patient cannot tolerate surgery. Ablation similar to HCC. Other types of malignant liver tumors include fibrolamellar carcinoma, which is a variant of HCC, epithelioid hemangioendothelioma, bad behaving tumor, even worse than HCC and cholangio, angiosarcoma and lymphoma. نكون هيك خلصنا المحاضرة الأولى تاعت liver tumors. Any questions so far? Any questions يا شباب؟ نبدأ المحاضرة الثانية ولا تكون استراحة؟
لا دي بس
عادي ما في مشكلة دكتور ممكن نكمل.
Okay.